Bismillahirrahmanirrahim. Assalamu alaikum. Today, the topic is hearing loss and its management. As you know, the hearing loss and its management, it is a complex topic. And for it, you must know about the physiology of ear and hearing. Anatomy of the ear, that is external auditory canal, tympanic membrane, ossicles, cochlea. This knowledge must you have, so that it will be easy to understand this lecture and this topic. So in hearing process, the physiology is shortly sound waves or vibrational mechanical force from the environment or from a vibrating source. That may be a person, that may be some other source. It is transformed into a electrochemical signal that is transmitted from the external environment through the external auditory canal, through the tympanic membrane, through the ossicles, to the base of cochlea, that is oval window, where the foot plate of step is closing that oval window. And these waves are transformed from environment in a form of sound waves into electrochemical signal. And further, it is transmitted through the eighth nerve, that is also called vestibulocochlear nerve, to the brain. And in this way, the sound waves are transformed and we get it in a form of some practical words. There are three main categories of hearing loss. Sensorineural hearing loss, which is also abbreviated as SHL, conductive hearing loss, and mixed hearing loss. So coming to the sensorineural hearing loss, it is a permanent hearing loss whenever it occurs, that the nerve is affected or some pathway between the nerve and the brain is involved, due to which this hearing loss is permanent. Sometimes the hair cells in the cochlea, which vibrates and which stimulated by a specific frequency of sound, these are damaged. So anything or any condition, any disease that may be systemic or local, which damages, which affect cochlea or retrocochlear, beyond the cochlea, nerves, cochlea, these pathway, if it is damaged, it is affected, then this loss is permanent. And sometimes the sensorineural hearing loss in some condition that may be prevented or stopped for, but permanently it is not cured. Like example is, if a noise induced hearing loss, exposure to a loud sound for a long period of time, that are people working in machinery, heavy machinery workers, or in factories, who are, as a part of their job, are exposed to high frequency sound for a prolonged period of time, there occurs a damage to the hair cells in the cochlea. And what happened? They got a sensorineural hearing loss. It is preventable if this person is brought back, or this person, due to some reason or some precaution measure, he can be no further exposed to such sound. But it is not reversible. That damage is not reversible. That person will having that hearing loss permanently, but it will not worse further. Thus, by uses, it is age-related hearing loss. That is, person beyond the age of fifth decade means above the age of 50 years in some people. It is also called senile hearing loss. In such person, the hearing loss occurs due to age factor. And it is not definite that this person may be exposed to occupational sounds. No. Then is socioacusis. This is hearing loss produced by exposure to non-occupational noise. Non-occupational noise, what do you mean by non-occupational noise? Means that not that much heavier sound that the patient with non-induced hearing loss occurs. No, these are not exposed to such sounds, but there are some other factors like some dietary elements or exertion, exercise, some lifestyle. These can affect, these may contribute in such hearing loss. And the fourth one is nosocosis. This is hearing loss is attributable to a disease. These patients, these persons is having some autotoxic effect. Some autotoxic effect are there due to which these person are get the sensorineural hearing loss. And occupational hearing loss and head injury. Yes, head injury can cause some damage to the cochlea or nerve that can cause a permanent sensorineural hearing loss. Virus, whenever it viral diseases that can damage the apical nerve or the cochlear nerve, that can cause an autoimmune diseases. In children, hearing loss. In children, it is a sensitive age group, and if hearing loss occurs at this age group, these children will be unable to speak properly, or they may have some language development difficulties. The babies or the infants, the baby which start to appreciate sounds of their mother or their to whom they are close, or some other environmental sounds, or they try to speak out some word, that is after the age of 6 months usually. So this age group is a very sensitive age group in which they are in a learning phase, and it is also called prelingual stage. So usually some treatment which is offered to such babies or such children in a prelingual age. There are some syndromic hearing impairment. Syndromic hearing impairment, it means that there is some other systemic diseases in which hearing loss is as a part of this diseases, these syndromes. That is genetic mutation causing hearing impairment in some morphological or clinical features. This Alport syndrome is a condition, is a disease in which hearing loss is associated with some renal abnormalities, and the hearing loss is a progressive hearing loss. Then the Waardenburg syndrome is another condition. It is also childhood disease. It has two types, 1 and 2. In type 1, there is decreased hearing loss along with white forelock. That is a patch of, or you can get bunch of hair at the level of the forehead. They are white, and all the other hair, that is the normal black color. So it is also called a white forelock. And in type 2, Waardenburg syndrome, there is lateral displacement of the medial canthi. You must know what is medial canthus. Not me, your anatomy must be fresh at this time. Usher syndrome is another condition. It has also two types. In type 1, the hearing loss is severe, and in type 2, the hearing loss is a bit less severe. Then the Pendron syndrome. Pendron syndrome, in this, the hearing loss occurs along with goiter, but that goiter is euthyroid. Euthyroid means that if we do thyroid function test, that would be normal. but there is physically a swelling of thyroid gland in the neck. And these all are childhood diseases. Congenital infection like toxoplasmosis, syphilis, rubella, or cytomegalovirus, these also can cause the hearing loss. Craniofacial anomalies like abnormalities of the pinna or ear canal. It is also studied that birth weight of infant less than 1500 gram, or you can say 1.5 kg, it is usually associated with some hearing problem. Hyperbilirubinemia, autotoxic medications, these have a great role in the sensory hearing loss, especially aminoglycoside. And when aminoglycosides are associated with loop diuretics, this have a great impact on the hearing. That the person or a patient or a person using aminoglycosides along with loop diuretics for a long period of time, then it get affected this hearing. And some other medications, drugs like streptomycin is also gentamicin, streptomycin. These also are have autotoxic effect. Bacterial meningitis, mechanical ventilation like baby or a child for a long period of mechanical ventilation, that is a ventilator, due to some reason, due to some disease, such a child also develops hearing loss, hearing impairment. Hereditary malformation of inner ear, Meniere's diseases, autosclerosis, and tumors. These are all conditions in which hearing loss can happen. That was the sensorineural hearing loss. Now coming to conductive hearing loss. Conductive, you must be clear and you must have a clear concept about a conduction. Conductive hearing loss occurs any defect, any problem, any abnormality from the external ear up to the base of the cochlea, that is footplate of stapes or oval window. Any defect in this path will affect that will be come in the under the heading of conductive hearing loss. What happens that the defect in the transmission of the sound waves from the external environment to the cochlea. So one is the outer ear, then middle ear. What are the causes of the outer ear? Any stenosis, narrowing of the inner ear canal, or wax impaction, wax in the external auditory canal. This will obstruct the sound waves from entering the external auditory canal to the tympanic membrane, and therefore the hearing loss will be conductive. Obstruction caused by foreign body. Foreign body again will affect the obstruct the sound waves from entering the ear to reach the tympanic membrane. Exostosis. This is an abnormal bone formation in the external auditory canal, and that also act as a blockage. Otitis externa. Otitis externa is a condition in which the external auditory canal is get infected due to some reason, due to some disease, and it again cause obstruction. So in all these, and microtia, this is also a congenital abnormality of the external auditory canal. In all these conditions, we have seen that the sound wave is obstructed by one or the other way to enter the reach the tympanic membrane. And if the sound waves are not properly reaching the tympanic membrane, there will be conductive hearing loss. Now the middle ear, if there is perforation in the tympanic membrane, and tympanic membrane is perforated, ruptured due to any reason, either due to injury or infection, or due to some rapid changes in the pressure that we barotrauma, which is called a barotrauma, deep sea divers, or the plane at a very high altitude. Such conditions can occur in pressure difference between the external environment and the middle ear cavity. Anyway, perforation of tympanic membrane, if occurs, again the hearing loss will be conductive, because tympanic membrane is ruptured and sound waves from the external environment reach the tympanic membrane, but tympanic membrane is not there. There is perforation, and the ossicles are not properly vibrated. Tympanic sclerosis, this is the hardness, this is the thickened, hardened part in the tympanic membrane that do not properly vibrate. Next is the otitis media with effusion. This is a very important thing. Otitis media with effusion, it is also called OME. It is the fluid in the medullary cavity. Usually a disease of the childhood, children. It occurs in the children, usually, very rarely in the adults. And what happens is tympanic membrane, due to fluid in the medullary cavity, tympanic membrane doesn't move properly inward. And what happens that the sound wave conduction is again impaired. Eustachian tube dysfunction. Eustachian tube dysfunction or blockage. This can also cause cholesteatoma. This is a condition associated with chronic suppurative otitis media. This can also cause conductive hearing loss and glomus tumor. This is a tumor which extends into the medullary cavity. All these are obstructing the sound waves from entering to reach the cochlea. Mind it and remember it, all these points. Ossicular ossicles, that incus, malleus, stapes. If there is some abnormality, injury, trauma, anything that can cause discontinuity of the ossicles, again, the sound waves will not reach properly to the footplate of stapes or whole window to produce the proper conduction. And autosclerosis, this is at the end, starting from the external environment, we are coming step by step from the external auditory canal, the tympanic membrane, and then the medullary cavity. Now, the autosclerosis is a condition in which the footplate of stapes is fixed at the oval window. All the other pathway is normal, but the sound waves when reach the footplate of the stapes, it is unable to move it into the cochlea. No vibration or no electrochemical stimulus is produced. So they may cause a permanent hearing loss. These ossicular discontinuity and autosclerosis, they can cause permanent hearing loss. These conductive hearing loss may be treated with either some hearing aid or bone anchored implantable devices that we use for stapedectomy or use an implant for in the case of autosclerosis. Then it will be taught you when the ear disease will be started to teach. Then mixed hearing loss. Mixed hearing loss is any combination in which the sensorineural and conductive hearing loss both come in the same patient, in the same ear. So, because it is possible that two pathologies maybe come at the same time, maybe in the same time, in the same year. Suppose if the ear sustains some sort of trauma, there is some previous conducting hearing loss. You can say that a person with having perforated TM and gets some trauma, temporal bone fracture, the 8th nerve is also damaged, or the cochlea is damaged. So the patient is also having already having some conductive hearing loss, and the sensorineural hearing loss occurs at the same time. Or if one hearing loss is compounded by another, a long-standing conductive hearing loss with patient with long-standing conductive hearing loss, either due to, you can say, tympanic membrane perforation in the ages above 50 or 60, and the patient goes a senile or presbycusis. So presbycusis is sensorineural hearing loss, and tympanic membrane perforation in this patient is having conductive hearing loss. Both come at the same ear, and the disease is called as a mixed hearing loss. So symptoms in mixed hearing loss will be some combination of the two types of hearing loss. Simple. We do a tuning fork test. This is a part of examination. Weber's and Rennie's. And Weber's, we can differentiate about the conductive hearing loss, which side is more. And REN is simple. In REN is we look for the bone and the air conduction separately in the right and left ear. These are simple tests and manually we do. And especially it is done with low frequency tuning fork, that is to 12 hertz, 512 hertz. And it gives us a quick indication of type of hearing loss, that is unilateral, bilateral, conductive, or sensorineural. Diagnostic radiology. This is the point and importance of all these tests, in which, on the basis of which we are able to diagnose a person, patient, child, infant. On the top of this is auditory brainstem response, ABR. It actually shows us a retrocochlear defect dysfunction in a patient. The next is autoacoustic emission. Autoacoustic emission and ABR, both are a very important investigations, and on the basis of these two investigations, we can assess an infant whether the infant or the baby is having some congenital hearing loss, even just after birth. So newborns are screened for hearing loss on the basis of these two investigations. So remember these two investigations, ABR and OAE, that is about autoacoustic emission and auditory brainstem response. So if a baby is having if we have to screen such babies or children, so we have to do these two tests. Next is the pure tone audiometry, PTA. Actually, pure tone audiometry, PTA, is also a very common test, and on the basis of this we can differentiate between whether the patient is having normal hearing or conductive hearing loss or sensorineural hearing loss. Normally, there are normal range for a pure tone audiometry. For adult, it is 0 to 20 decibels. So if a person is having normal hearing, it will come in the range of 0 to 20. But for children, it is not 20, it is 15. And the reason for this is that the children are in a phase or age of developing speech and language. And if on pure tone audiometry, the range exceed 15 decibel, so it is labeled as some mild hearing impairment. So for adult, this is, for a children, it is not 0 to 20, it is 0 to 15. For adult, it is 0 to 20. So that further impairment can be assessed. This is the main reason. Admittance measurement and temperature we will discuss later. Calculation of word recognition score. This is to whether the patient can having a proper speech or can, again, hearing is proper or not. This is just a rough or calculation or recognition of the patient. Electrocochleography. This investigation we usually use for a diagnosis of Meniere's disease, which is an adult disease. Now come to the degree and level of hearing loss that we have. I have told you that there is normal range on audiogram. Audiogram is a graph on which it is reported or labeled. 0 to 20 is a normal. For adult, we are talking about adult now. So for adult, it is 0 to 20. For children, normal region on the audiogram is 0 to 15. On mild hearing loss, the values are 20 to 40. 0 to 20 is normal. 20 to 40 is mild hearing loss. 40 to 60 decibel, that is moderate hearing loss. And if it is below 60, that is severe hearing loss. And if it is greater than or below 90, that is profound deafness. It is called profound deafness because below 90 degree of decibel hearing loss, it means that the person is not hearing, he's not hearing almost. And even a hearing aid cannot help. So normal value is 0 to 20 in adult, mild 20 to 40, moderate 40, 20 to 40, moderate 40 to 60, and severe below 60 and profound below 90, greater than 90. Now comparison of hearing threshold for air versus bone conduction, that is air conduction and bone conduction. So whether a hearing loss is sensorineural, then the audiogram, there will be no air-bone gap. These are plotted, the air conduction, bone conduction are plotted in the graph. For conductive, bone conduction will be normal, but there will be loss in air conduction. In mix, there will be loss of bone conduction with superimposed air-bone gap. Impedance, admittance, these are the terms. Impedance, measuring of the middle ear function. Actually the measuring of the middle ear function is to look for the tympanic membrane, whether it is vibrating properly in and out or not. Impedance means it is grammatically means resistance. Impedance, you know, admission, that is entrance. So when this tympanometry is a test, is a device through which we check the middle ear function through this tympanometry test to look for whether the tympanic membrane is properly moving in and out, because when the sound waves touches the tympanic membrane, reaches the tympanic membrane, it causes vibration in the tympanic membrane, and then the ossicles, and then it will go beyond the ossicles up to the cochlea. So if there is some obstruction, like if there is fluid in the middle ear cavity, then the middle ear cavity, instead of having air, will be having fluid. So when the sound waves reaches the tympanic membrane, touches the tympanic, it is unable to vibrate the tympanic membrane or move it inward into the middle ear cavity. So there will be no movement in the ossicles and everything will be stopped. So this is the impedance, resistance to the waves which comes through the external auditory canal to the tympanic membrane. Tympanometry is the continuous recording of the middle ear impedance as air pressure in the canal, and it systematically increases or decreases the test. And we do it for the otitis media with effusion. Hearing aid. These are devices which is used for treatment of patients with hearing loss. And this is assistive device that delivers an amplified acoustic signal into the ear canal. Electronic hearing aid consists of, it has a part, it has three basic components: microphone, amplifier, and receiver. Cochlear implant, this again is a thin electrode which is inserted into the cochlea. It is a microphone, speech processor, and transmitter. Sudden sensorineural hearing loss presumed to be a viral neurogen, maybe. It is sudden hearing loss, then it is viral neurogen. One thing I should told you that cochlear implant we do in children in below the age of 2 or 1 year. If it is diagnosed as a congenital hearing loss, complete hearing loss, sensorineural hearing loss, so this cochlear implant is inserted for as a treatment, right? And the sudden sensorineural hearing loss presumed to be a viral intrusion can be a autologic emergency. It can be treated with corticosteroids, and sometimes it is get cured. Corticosteroids may also be used locally to reduce this inflammation, swelling after exposed to a loud sound. Other treatment depends upon the disease. What is the disease? Number one. And second, which type of hearing loss is there? Depending on these, medical and surgical treatments are advisable. For wax infection, you do suction clearance, clear the wax. If the ear infection, you do treat by antibiotics. If the foreign objects are there and it is removed, if any abnormal growth, surgical procedure are done. Or hearing aid or cochlear implants, all these are treatment options. Treatment option of mixed hearing loss. It will depend upon whether the loss is sensorineural hearing loss is more or conductive loss is more. So that is treated in that regard. So if the conductive component is greater, again the surgical procedure and medical treatment is effective. If the greater portion is sensorineural, the hearing aid and implants devices may be the best option. Thank you.